Good afternoon and welcome to a presentation of maximizing MOPs Propel protocols in a COVID-19 environment. And my name is Dr. Gary Brigham and I'll be hosting this afternoon's event. Now, my experience with MOPs began in 2013, and since then, as a solo practitioner, I've conducted over 620 MOPs procedures, the majority of which have been full arch. Now, I've had the opportunity to participate in the beta testing of the Accelerator PT device, and currently serve as an adjunct professor of orthodontics at the A.T. Still Orthodontic Program in Mesa, Arizona, not only as the dedicated Propel, but also the dedicated Invisalign instructor. In addition, I serve both as a consulting member of Propel's clinical board, as well as a mentor for your ortho coach. Now, you'll be able to ask questions at the end of this webinar, so I'll be looking forward to hearing from you. And just to get through with the disclosures, in order to get your CE credits, I'm not employed by any orthodontic company. I don't own stock or securities. I don't have a family member that's employed or owns any stock or securities in any orthodontic or dental company. And I have consulted and evaluated products for some organizations, including Propel Orthodontics and also Align Technology. And sorry about this, but I have been compensated in the past for consulting and or evaluating products for the sponsors, including Propel. And for my participation in the presentation, I'll be receiving your honorarium. And also the materials in this presentation are for educational purposes alone and are not to be used for advertising or product endorsement purposes. And this presentation has been approved for continuing education credits. And this is one of the prerequisites for going through these disclosures with you. And again, no photographs, video, or audio recordings are permitted during the presentation. All right, now that we've got that out of the way. Now, this isn't for shock value, but I'd like to start this with an actual true story of what happened. This young man actually flipped over on a mountain bike, and he went obviously face planted. And his fiance happened to be a nurse who was one of my Invisalign patients. So the interesting thing about this is that my practice is directly across from Scottsdale North Hospital. But instead, the nurse said, let's go see Dr. Brigham. So he comes in and sits down, and the guy is a wreck. And he feels that he's lost his smile forever. And I said, no, I said, I can see a smile in there. And he said, you got to be kidding. I said, no, my job's to bring it out, but I don't do blood. So I said, so why don't you go across the street to the emergency room, get that all cleaned up, and then come right back, and I'll stabilize those teeth because they were all mobile from canine to canine. He really cracked them all up. And so naturally, he comes back already stabilized. A surgeon actually convinced him to go ahead and stabilize him with this, and then proceeded to charge him about $3 grand for this, which I was willing to do at no charge because he was, spouse of one of my friends, friends who was a patient, the nurse. So obviously, you can see that his bite isn't quite right. He had some edema in the left condyle, so that will actually open up the bite. So what we did was we put him into an oral orthotic for about 3 months until we got a stable, repeatable position on the occlusion. And then you can see he also he had a zygomatic fracture, so he got that stabilized. And so then he comes in and he's still rather depressed, and although I thought he was looking pretty good under the circumstances, but that's when he proceeded to tell me that he was planning on getting married in 7 months, and he was just a wreck. He just said, do you think I should postpone the wedding? I said, no, I think we have a solution for you. Let's do Invisalign Comprehensive, but you're going to have to do MOPs. You're going to have to go through. And I explained the procedure, and he said, can you guarantee that I'll be all ready for the wedding? Because I'm going to have to get some crowns on these teeth. And I said, only God makes guarantees, but my experience is we're going to have a good crack at this, so let's get going. So the first thing we did was we did things simultaneously. He needed some root canal treatment on both of those central incisors. We did an in-house whitening treatment. We used the glow whitening system so we can get the best situation that we possibly can. Then we proceeded to go ahead and we did all the composite recontouring of all 4 maxillary incisors, and we also built up that right maxillary canine, and then we scanned them all on the same day. And after 26 aligners in 2 months and 3 weeks on a 3-day aligner exchange with MOPs, he's looking pretty good, but we still got some time, so we've got to get him into a refinement situation. And that's, I use a lot of digital smile design, not at the beginning of treatment, but at refinement, because I find that, when I'm looking at the patient in the chair, it seems to be okay, but with doing digital smile design, I noticed that he's still got this cant. So, and I wouldn't have noticed that if I hadn't been staring at these photographs and comparing his digital smile design. So we put him through a second round of aligners, and this time it was 30 aligners. And here he is finished in 5 months and 3 weeks, plenty of time for the wedding. So he took off his attachments and he ran out to his dentist to get some crowns so he could have good wedding pictures. So I can't tell you how grateful he was. He just said, I just never thought this was humanly possible, and very happy, and I'm certainly had a happy wedding. So this is one of the principal reasons why I incorporated MOPs into my practice. Now, first of all, it was an opportunity to treat and finish more challenging clear aligner cases without surgical trauma or sequelae. And it provided increased opportunity to attempt to incorporate smile arcs into clear aligner finishes, which gives me better finishes. I wish I could treat the first 1,000 patients that I treated with Invisalign all over again, because I wasn't incorporating smile arcs. When you do that, it adds more aligners to your treatment, and it's a lot more difficult to extrude maxillary incisors unless you have MOPs. And the other reason, it just increases patient acceptance of treatment when they find out that you can really significantly truncate your treatment. And I find that having reopened after this COVID situation, I just simply find that patients are still focused on how fast can I get out of treatment. So they're still willing to undertake MOPs. And I was pleasantly surprised at that, and I'll talk about that a little bit more at the end of this webinar. But more important, I'm getting a lot of appreciation from patients for fewer appointments and significantly faster treatment. And more than ever before, this is important after this COVID. Actually, we're still in this COVID situation. So what we're going to cover tonight is going to go over a brief history of surgical disruption of alveolar cortical bone to accelerate orthodontic tooth movement. I'm going to explain why we accelerate orthodontic tooth movement with MOPs. I want to go over the science as well as the devices that support MOPs, and talk about the convention and updated MOP treatment protocols in the COVID environment. And then we're going to talk about case selection and challenging tooth movements. So let me just go over a brief history. I don't want to get bogged down with this, but the reality is, alveolar cortical disruption has been going on for 100 years. It was first introduced by Bean back in 1892. And when Cole introduced a full flap surgical technique, that was a real eye-opener. But it wasn't until 1989 that Frost coined the wrap phenomenon. And that was a little less aggressive than the full flap surgical technique, but it was still pretty invasive. And then, of course, the Wilco brothers introduced Wilcodontics at the AAO back in 1998, and that caused everybody to stand up because they demonstrated significant accelerated orthodontics. Problem was it was rather invasive. And then Propel patented their proprietary stainless steel tips in their device back in 2010. So really, there's been over 600 peer-reviewed clinical trials on perforation and corticotomies. And there's also been a lot of significant acceleration that's been documented with orthodontic tooth movement. But the problem is it's traumatic. It's significantly traumatic, and because it creates large flaps and extensive corticotomies, and sometimes these procedures are 3 to 4 hours. So it's met with a lot of resistance, not only from patients, but from clinicians as well. No one really wants to get involved with these type of surgical procedures, in spite of the fact that we know that they definitively work, and they most assuredly accelerate orthodontic tooth movement. So what evolved from that is a less invasive procedure called piezo-excision. And it's a flapless corticotomy that's designed to reduce morbidity associated with conventional corticotomy. But it also involves using vertical incisions with a scalpel and a piezotome to actually perform the corticotomy. So it's still traumatic, far less traumatic than Wilcodontics, but it's still traumatic. It does provide you an opportunity to inject some bone grafting in there too, some bone spicules. So in that way, it helps, especially if you've got thin biotypes. But the bottom line is the universal problems with these invasive corticotomies and corticostations is that they're significantly invasive, no matter how you look at it. And there's always some possibility of morbidity following a surgery. It requires a whole bunch of surgical armamentaria, It does require sutures, and it requires the use of antibiotics. And I think the profession is beginning to understand the overuse of antibiotics because no one talks about what it does to your gut. And then we talk about the procedures are simply impractical for everyday orthodontics. There's a significant lack of patient acceptance as well as a lack of doctor acceptance. And in a COVID environment, these procedures are simply not prudent. So why accelerate orthodontic tooth movement with MOPs? Well, first of all, there's been new additional demands since we've gone through this COVID environment. Previously, with MOPs, I had patients that they just come in and they don't want any appliances that are going to interfere with their lifestyles. So they don't want any earthed appliances. I even had trouble putting wires, and they were complaining about that because it interfered with their mouth guards or whatever. And then they wanted shorter treatment lengths that coincide with their new personal expectations, and their new personal expectations are they want to finish treatment in less than a year. And now they also want minimal office appointments that accommodate their schedules and then address their new infection control and social distancing concerns. So there's a whole additional group of concerns that they want, but they still want to accelerate treatment. And that's the pinpoint. That's what they focus on, and that's what MOPs delivers. So where did these attitudes come from? I think what happened with social media. It turns to changes attitudes and shapes expectations, and it really, in a lot of situations, rationalizes behaviors. And in addition, there's marketing, and what marketing does, it ultimately drives consumer decisions. And then on top of that, marketing also distorts patient expectations. And I think this is one of the classic examples with 6-month smiles. Patients keep seeing that and they honestly start to believe that you can do orthodontic treatment in 6 months. And of course, Smile Direct Club hasn't helped with much because they advertise that the average treatment time is 6 months. And if you just, now they're talking about nighttime clear aligners for 10 months, and all you have to do is wear 10 continuous hours for the nighttime wear. So all of this just simply serves to distort patient expectations, and they bring these unrealistic expectations in the office. They all want perfection, but they all want to do it in what they think is their own personal time frame. And then we've got new expectations of treatment in the COVID environment. They still want treatment, but they're even more concerned about the length of treatment, more concerned about the time spent in the office, and of course they're asking about infection control measures. So more than ever before, I think orthodontic practitioners today are now faced with new and challenging treatment time constraints that we haven't faced in the past 5 to 10 years. And when you look at these changing expectations, and actually this research is actually dated in terms of the expectations now, but they found that there's a difference between teen and adult expectations. Teens expect to be finished in treatment in less than 12 months. Adults expect it somewhere between 12 and 18 months, a little closer to what the standard was. But adults still wish that treatment could be completed in 6 to 18 months. So right now, what I'm getting is I think patients show disappointment if I talk 10 to 12 months. So it's becoming more and more of a time constraint in treatment. And you know, as an orthodontist, you get all the most the complicated, complex cases. So it's getting exceptionally challenging. So right now, the acceleration modalities are MOPs, the high frequency vibration devices, photobiomodulation, low-level laser, periodontal acceleration, the Orthodontics ones, and then the ultrasound where it mounts throwing some gel into a tray and having the patient put that in the mouth. I can tell you that's not going to run very well because I can't even get patients to follow treatment plans and wear elastics, let alone ask them to put some type of gel in their mouth twice a week. So that's why, from my own practice, I think that MOPs has been and will remain the current gold standard for acceleration. The most important reason why is there's no continuous patient cooperation required. You know, it's economically feasible and practical both for the patient and the doctor. It's minimally invasive, and more importantly, the science supports not only the efficacy of the procedure, but clinical results actually validate it over and over again. So I would like to just touch on the science supporting MOPs. I don't want to turn this all into biochemists, but it's important. And I think the reason why is if you have a clear understanding of the MOPs procedure from a purely scientific basis, when you've got that understanding, the knowledge that's based in science really generates patient trust. If you can look at the patient in the eye and explain what it is and why it works, and be clear on the science and how it's going to apply to specific clinical situations, you're going to get a lot greater acceptance. You have to be capable of explaining it in terms that patients understand also. So the terminology that I use is, I said, we've got a procedure to accelerate treatment. And what we do is we limit our Propel procedures to 2 days a week. And so I give them a choice, and I tell them, on one of those 2 days, you'll come in, we'll numb you up as if you were going to get some type of restoration of fillings. And then we have a device that literally pokes the bone in between the teeth. And then I tell them that the way it accelerates treatment, it gets the bone cells to turn over faster. So I tell them, so instead of flipping out your aligners every 7 to 10 days, now you can do it every 3, 4, or 5 days. And that's how we can cut treatment time literally in half. And I tell patients, my own personal experience, I get far better results because I can incorporate smile arcs with a greater degree of continuity and also with comfort. So I think the science has already been there for a long period of time that bone remodeling is simply an inflammatory process. And the rate limiting factor for orthodontic tooth movement is in bone resorption at the bone and PDL interface right here. And everyone knows that, all right? And also the rate of bone remodeling also affects the rate of orthodontic tooth movement. Of course, that makes sense. And it's an inflammatory process, and it's associated with the production and release of cytokines. And although I'm talking about a few of those, I'm certainly not going to be including all of them. One of the reasons why is that some of these cytokines, we know they're there during the inflammatory process, but we don't know exactly the mechanisms that help accelerate the treatment. But these cytokines stimulate osteoclast formation and function, which in part impacts the rate of bone remodeling and orthodontic tooth movement. So this is just a diagram just to give you an overview. But the bottom line is it all comes down to pro-inflammatory cytokines and chemokines. And once they engage an osteoblast, the osteoblast on the outer membrane has these proteins which are called rankle. And once they get hit with these cytokines, it stimulates the osteoblast to release rankle, and the rankle goes to find its rank receptor on an osteoclast precursor, which is usually a monocyte. And a monocyte is just simply a mononuclear cell. And what I want to also point out is if you notice that you've got MCSF, that also stimulates a monocyte to become a mature osteoclast. So once this monocyte gets hit with this rank-rankle connection, as well as the MCSF, it stimulates them to start to congeal and actually come together. And so if you got these cells actually coming together, now it becomes a or polynuclear cell. And that's all the difference between a monocyte and a mature osteoclast. It's the multinuclear cell. Once this is activated, it begins to immediately bone remodel. So what do we know about MOPs? Well, first of all, we understand the biochemical mechanisms of action. That's definitive. It's based on the rankle-rank connection, and also the fact that we've got another protein, which is that simply, once released, actually has an impact on creating mature osteoclasts. Okay. We also know or understand the physiological mechanism of action. Basically, it's mechanically induced microfractures. Once an osteocyte's membrane is disrupted, that's what releases the chemical or the biochemical reactions that we understand today, which induces osteoclastic formation. So MOP mechanically disrupts osteocyte cell membranes, and the mechanically damaged osteocytes simply secrete a number of pro-inflammatory cytokines and chemokines. Now, the only reason I threw this in is because I'm always getting questions of what's the difference between a cytokine and a chemokine. They're both proteins, all right? Cytokines are proteins that simply affect the behavior of cells. And in this particular case, it's affecting the behavior of osteoclasts to become mature osteoclasts and start bone remodeling. Chemokines are a type of cytokine that actually attracts cells to the sites of inflammation. So it's the chemokines that help direct the cytokines to the area where we want this osteoclastic activity to occur. So they work in harmony and they work in unison together. Now, this is just a flow chart, and I don't expect you to really look at this for long, but the only reason I've thrown this up is there's a huge difference between MOPs and all the others, all the pulse vibration, the low-level laser, and even the photobiomodulation. And when you look at it carefully, once you apply orthodontic force, and once you get some tissue damage, you're going to get this release of pro-inflammatory cytokines. And if you notice that that release stimulates the release of MCSF and the rankle, which is going to go on to form the rank-rankle connection. When you take a look at these other devices and these other modalities, you don't see the MCF release. Now, there is some, but it has to go all the way around the block here. And it's this long, long area before it actually has any type of impact. And so consequently, the release of this in these modalities is very minimal and, in my mind, inconsequential. So the real important thing is that when you're doing damage at this level, you're getting this cascade of these proteins that really actually have an effect on these pre-osteoclasts to form mature osteoclasts. And that's the reason why you can flip out aligners every 2, 3, 4 days with MOPs, but it doesn't work with any of these other modalities. Do these other modalities accelerate treatment? Yeah, I mean, the best I've done is about 5 days with a high frequency vibration. I've tried without it and it doesn't work. So the bottom line is MOPs is my go-to for acceleration, and I think it always will be. Now, when you think about osteoclastic activity, there's other ways to even accelerate it more. And it really makes sense. You can actually adjust the rate of bone resorption by simply increasing the number of osteoclasts in the area. And you can also increase the activity and survival rate of the osteoclasts. So you've got these additional possibilities for making this even go more significantly. And that's where MCS comes in. That stands simply for macrophage colony stimulating factor. But it's really an important protein. And because mechanically induced tissue damage stimulates the release of this, which is dependent upon bone marrow macrophages to differentiate directly into osteoclasts. So it's like passing go. In other words, it can actually supersede the rank-rankle interaction, which creates that osteoclastic activity, and it actually creates the osteoclastic activity by itself. So that's very highly significant. So once again, just in some, you've got these pro-inflammatory cytokines that hit the osteoblast, releases the rankle, that goes to find the rank. Now we've also got this osteoclast differentiating factor that's expressed from the osteoblast by these cytokines. And what it does it two things. First of all, it binds to the rankle receptor, so it really helps direct this. It's like a director or a parking lot attendant, okay? But it also has effect on MCF, so it gets directly to these multipotent progenitor cells, and it actually allows these to act predominantly on these cells to differentiate directly into mature osteoclasts, directly and very quickly. So that's why this is very important, very important. So that's why it's a particularly important cytokine. It rapidly and potently augments rankle-induced resorption. It dramatically stimulates osteoclast motility and spreading, and it enhances osteoclastic survival, migration, and chemotaxis. So this really is the difference, and this is why MOPs works so dramatically. Basically, MCS simply serves to caffeinate osteoclastic activity. So just to sum this up, Propel's proprietary surgical stainless steel tips are designed to maximally microfracture cell membranes. And these damaged osteocytic cell membranes induce significant cytokine and chemokine release. And the enhanced osteoclastogenesis in the presence of orthodontic force is what creates the accelerated orthodontic tooth movement. And one thing that came out in the past several years is that once you do this mechanical disruption of the membrane, these chemokines have quite a radius. It's actually up to 10 millimeters in terms of radius. When I learned that, that's when I started reducing the number of perforations, and I'm finding that it just works equally well. So I really found, based on this literature, that I was sort of practicing overkill with the MOPs. You don't have to put, there were times I was doing 3 and 4 on each side, especially on canines. That's not necessary. Rely on the cytokine chemokine release to do all this disruption and osteoclastic activity. That's the key. It's not the damage, it's the cytokine release. Now, This is an example of why it's critical in my mind to understand the science. This is an article that just came out in 2018, and it was actually published in our own beloved AJO, which is remarkable. All right, sorry about that, because it's usually very significantly vetted. But what's wrong with this article? First of all, none of the inflammatory markers that are de rigueur for measuring for any type of acceleration were not measured. And then the report actually indicated that a mini implant screw was used instead of Propel's proprietary stainless steel tip. And they inserted it a 3 to 4 millimeter deep to account for the soft tissue thickness of 2 to 3 millimeters. Now think about that. If the soft tissue was 2 millimeters and you only went in 3 millimeters, you're not getting into the cortical plate. And more importantly, what they used to disrupt the cell membrane was an R-house mini implant screw, instead of using the Propel proprietary stainless steel tip. Now, the reason why that's significant and hugely problematic is because TADs are not stainless steel tips. They're titanium. And not only that, but if you go right to the R-house's booklet on Anchorage devices, they take pride in the fact that these TADs provide minimal damage to the cortical plate. And why? Because you want your TADs to stay anchored in the cortical plate. So even small differences have substantial effects. And the surface treatment mini implant can provide much less bone damage. In addition, these TADs are only 1.5 millimeters thick. Even the thickness or diameter of these has a bearing on the amount of damage that it does. Propel's proprietary tips are 1.6 millimeters in diameter. And yet, on the basis of that article, we have a relatively famous blogger who's got a very large following that puts this cartoon and with the title, "We Won't Get Fooled Again, a New Trial on Speeding Up Tooth Movement." Now, obviously, this type of connotation is that MOPs is just, it's just ridiculous. It doesn't work. And with that cartoon, it just helps to show that it's, it implies that it's highly invasive. And if you read his article, and I know that a lot of doctors just take a look at the heading, they take a look at the first few paragraphs, and then they draw their conclusions, like this blogger did, that this MOPs is there's no evidence to suggest that it works. But if you look at the fine print, he said, interestingly, instead of the MOP proprietary screws, they use the mini screws. And I'm not sure if this differs from using a Propel device. And it would seem that both methods seem to cause the same amount of localized trauma. So here he is formulating an opinion without understanding the science. And the problem with that is that he's got a large following, and that large following tends to rely on the information that on his blog as absolutely correct. So I'd like to be very definitive. There's a huge critical difference between TADs and Propel's stainless steel proprietary tips. They're designed to limit microfractures. That's what TADs are. And they come in all sorts of shapes and flavors, but they want to limit the inflammatory response. But on the flip side, Propel's uncoated stainless steel threaded tips, and even the threads are specifically designed to maximize micro damage. So they're designed to maximize microfractures and the inflammatory response. A huge difference. And yet I still have doctors saying, well, I use TADs. And so it makes absolutely no sense to me. And then we have this misdirection continues. We not only had the Al-Kabesi article, but where he used a TAD that was only 5 millimeters in length. You're not even perforating the cortical plate enough, And then we had a follow-up article, and they again used TADs, and they concluded that MOPs was unable to accelerate canine retraction. Of course, you're using a TAD. And then we have research that fails to parallel the clinical experience. Now, I appreciate the fact that they used Propel's proprietary tips, but the problem that I have is, and they did show acceleration, of course, but the most important thing is they were using the MOPs every 28 days. That's not reasonable. Propel, in my own clinical experience, lasts about anywhere from 3 to 4 months. And if you top that off with a high frequency vibration device, you can extend the Propel effect another month to possibly 2 months, especially if the patient is very compliant. So it doesn't make sense to me to do a study and to conduct the Propel procedure every 28 days when that doesn't mirror the clinical experience. Now, we do have research that actually parallels experience, and this was one by Cho. He actually conducted MOPs, and he used Propel's proprietary stainless steel threaded tips, and he found that with a 3-day aligner exchange with MOP versus a 14-day exchange suggested, he found that MOPs was actually accelerated, and it was clinically and statistically significant. And then we have another investigation that they actually went back with fixed appliances, the canine retraction in first bicuspid cases using MOP's proprietary stainless steel threads, and they actually found a very statistically significant difference in acceleration. The only problem is, once again, they incorrectly reported the diameter of Propel's tip as 1.5 millimeters when it's actually 1.6 millimeters. So once again, here you are, you're going through the trouble of doing all this research and you just left out one little important tip. And this is what causes confusion, right? So by now you should be acutely aware of the fact that unintended consequences of less than adequately planned laboratory and clinical trials investigating the efficacy of MOP can have some real, residual problems. And there's also the perils of misdirected conclusions that can arise from this type of research. And that the effects of misinformation that are dashed off on professional social media platforms can really be truly misleading and help create or at least contribute to a lot of this confusion and a lot of the skepticism regarding MOPs. So I'd like to just review the MOP devices. So although I've used all of them in the past, I really lean towards the accelerated RT simply because it was so much easier to use than the original. But as soon as the accelerated PT came out, I summarily abandoned the accelerated RT because once you start really embracing MOPs as a legitimate acceleration, and you do an awful lot of them, this is the only way to go. And at this particular point in time, I now own 3 of them because if I don't want one to go down if I've scheduled 4 MOPs in one day, and we've got to go ahead and accelerate the tips and the contralateral piece on that connects to it, the motor. And also these are throwaway, we don't reuse them. So, and even on brachycephalic, sometimes I'll use 2 tips because sometimes going through that bone is like going through concrete. But they're autoclavable, it's a wonderful appliance, and it's got great advantages. It can be used for any appliance, whether it's braces or aligners. It can even be used with motion appliances. It requires 0 compliance. All the patient has to do is show up. It facilitates more predictable tooth movement. It affords customized biomechanics. You can do unilateral expansion. You can do apical root torque. I even use it for all my palatal impacted canines. And it's been found to be more root protective because if you're decreasing the bone density, you can really go through those. And when I followed through on patients that even decided unilaterally to go ahead and flip them out every 2 or 3 days, I haven't found any evidence with CBCT analysis of any more root resorption than I would expect. And definitely there's pain reduction involved with that because you've got, again, decreased bone density, so the patient can literally flip out these aligners quickly. Now I started off with the conventional MOP protocol, and that was, it was very simple. I always advise my patients to eat lightly 2 to 3 hours prior to the appointment because I didn't want them eating afterwards because I felt that they'd be sore. I always ensure that they take 1,000 milligrams of Tylenol 1 hour prior to the appointment. I've had patients come in and forget, so then we just give them 1,000 milligrams at the chair before we start the procedure. We advise them not to substitute Tylenol with Advil or any other NSAIDs. And that's there's obviously important reasons why, because we've got an anti-inflammatory response, and what we want is that inflammatory response. But this was the conventional setup, and this is when I was using the RT, and here's the base. And as you can see, we get out these gauze lengths for the 3 to 3s on the mantle and for the 5 to 5s on the upper. Sometimes it was 6 to 6. And the nice thing about these gauze, you just lay them in there and they'll stay there by themselves. And with the mouth retractors, so that's to make sure that they didn't swallow any of the BTT gel. So it was just a matter of evaluating the treatment area, palpating the tissue, checking it with the panel lips for your root position, but you can really palpate these roots. It's not difficult. The chlorhexidine rinse 2 times for 1 minute, and then we just go ahead and accelerate, and anesthetize and then accelerate with the BTT. And the BTT it actually comes in multiple flavors. It's not really that important, but it also came with the oral syringe and the adapter that was included, and it provided profound topical anesthetic. And here's the mix of lidocaine, tetracaine, prilocaine, and phenylephrine. And it was a matter of just, we use this little mouth condom here, and then we go ahead and apply, and you can literally walk away. We just kept an eye on this so that the patient wouldn't move, so that this wouldn't be dislodged. We were going for 3-minute applications. Because we found through experience, if we were doing 4, you got a lot more tissue sloughing, which made me more uncomfortable than the patient, actually. And then you test the efficacy of the anesthesia, and then you go ahead and initiate the microosseous perforations. And here's the MOP procedure completed with the BTT, and you can see there's some sloughing, but believe it, I never had a patient express any concern. By the time they got home, they were fine, and they were still on their Tylenol, so it wasn't really a problem. To me, at least to my auxiliaries, it looked to be something to be concerned about. What we found after doing the first dozen, that wasn't an issue at all. So, and we don't make an issue out of it at all. So I'd like to go offline here again so I can show you actual video of the actual procedure. Obviously, that video was taken obviously before COVID, so we've changed quite a few things. But the reason why we did that video is some doctor had done a video or a demo of MOPs, but he did it to Metallica music. And so I had a couple of patients that had signed on for MOPs. They went home and they just went on the internet and they saw it and it scared the hell out of them. So they came back and they decided to just go with a vPro. So I thought it was prudent that instead of directing them to the internet, we directed them to this video. So uh, anyone that's listening, you're more than welcome to, we'd be more than happy to send this video to you. And you can just chop off the end of it. So, or you can edit it for yourself so that it doesn't say Brigham Orthodontics on it, but you're more than welcome to it. Because when the patients see it with the a little bit more pleasant music, they seem to be more enthusiastic because they see that it's not anything except poking holes in the bone. Exactly what I told them. So I just want to address some of the most frequently asked questions regarding MOPs. And one of it is, how is the spacing between perforations planned? And just like I said, rely on the chemical effect of the perforations of 6 to 10 millimeters apart. So spacing the MOP should be planned accordingly. So you're going to see on some of these cases that I'm only doing one perforation on the lower end between the incisors, unless I want to do some significant axial inclination correction. So I'm averaging about 2 perforations in between each tooth, and on some situations, depending on what I'm doing, just 1. All right. How many perforations are necessary? 1 to 3. The only time I'm doing 3 is if I really have to do 10 to 20 degrees of distal root tip on a canine, then I'm going to go 3 on each side just to make sure. But for the most part, it's just 1 to 2. All right. And the remodeling is proportional to the insult. So remember that. And how deep should the MOP be administered? Typically 2 to 3 millimeters beyond the cortical plate. So and if you include the soft tissue thickness, that's about 4 millimeters total. And Propel's stainless steel tip is 7 millimeters, so the depth should be just about over half its length. So the clinical advantages of MOP are clear. Accelerating simple to complex cases and addressing challenging individual tooth movements. So now I'd like to present an updated MOP protocol, which is the one that we currently use, all right? Especially when we now know that social media is shaping our patient fears and our response to the coronavirus. So, I mean, the reality is we didn't have social media at our last virus, which was the SARS virus. And now that we have these social media platforms like Facebook and Twitter, what they're doing is facilitating not only important conversations about the virus, but also at the same time, they're allowing a lot of sensationalism and misinformation to spread. And patients feed off this because they think that social media is actually the news. In addition, we know that with these social media platforms, they go on algorithms, and these algorithms are designed to promote content that garners the most engagement. And we all know that shock value or emotionally charged content garners the most attention. So that's what they favor online, and that's problematic. And then in addition, we've got this new COVID world as well as a post-COVID world, and we don't know where this is going to take us. So the way we've responded is, I hope you can see these lucite screens to separate the patients from our front desk receptionist. And then what I learned from going to eye doctor during COVID, I saw all these signs in every single operatory, and I asked one of his assistants why that was necessary. He said, because we were getting bogged down with patients coming and asking, is this room disinfected? So what we did is we put signs in every single operatory as well as at the front desk. And sure enough, we don't get questions of, is this room being disinfected in between patients? And also we have these friendly reminders to make sure that they not only wash, but use the hand sanitizer that we spread throughout. And this seems to instill some degree of confidence, and especially important since we're doing a microsurgical procedure. So what this calls for, in this environment, is renewed emphasis on MOP's treatment and its efficiency in not only treatment delivery, but in reduced chair time, significantly shorter treatment time, fewest appointments possible, and now with the with the internet, we can do virtual management of patient care. So MOPS is the basis for providing this reduced chair time and shorter treatment times, and also the fewest appointments possible. And with our updated protocol, what we always did was, and by the way, you can get this at Walmart for about 25 bucks, but we always took a blood pressure in the chair before we even began any type of MOPS procedure. And out of all these procedures, we've only turned down 3 patients. One was a 35-year-old woman that had no idea that her hypertension was sky high, and we sent her immediately to her physician. And she came back later on with controlled blood pressure and actually a lot of gratitude because she had no idea. And so she's now on blood pressure medication. The other 2 were patients that were using recreational pharmaceuticals, and you could see by the dilated pupils. And so we're not going to be injecting any lidocaine into those type of patients. So we sent them home without making them feel uncomfortable. We just felt that they, would be better off not undergoing the procedure. And now with COVID, every single patient, we take a temperature on each patient, and we not only obtain it, but we document it. So make sure you document not only the blood pressure, but also the fact that you took a temperature and what that temperature exactly was. And so now we've abandoned BTT and we've gone directly to 20% topical benzocaine. This is one of the brands that we use, but they come from various dental vendors and it's very easy to use. It's the same procedure basically. It's just brush your teeth and rinse with the chlorhexidine, dry the vestibule with a 2x2, apply the topical, and the reason why we like it, there's no sloughing whatsoever. And we wait for about 2 minutes and then rinse, and then we just go in with buccal infiltrations, a mental injection, and some additional infiltration, especially in the labial frenum, because that's, you've got this extra nerve sensory there. So we don't, and if I'm going near that, I don't want that to be stopping the procedure and having to re-anesthetize. So although this sounds like a lot, it's really nothing. And the reason why the advantage over the lidocaine, over BTT, is you just simply minimizes the bleeding, as you saw in the video. And there's no sloughing of gingiva, and the patient doesn't swallow the anesthetic. We've had a couple patients move and accidentally swallow it, and that actually caused a lot of concern. But another thing, we also found that some of these, since we can't control the amount of lidocaine they were getting, that some patients were getting some headaches. So with controlled reaction with these lidocaine and the benzocaine, we've had no patient headaches, no treatment sequela, and more importantly, no sloughing of the gingiva. So there's some anatomical considerations with MOPs too that should be considered. And the first question is, what's the depth necessary to initiate osteoclastogenesis? Now, Alicani in his first article found that he was getting successful tooth acceleration with just 2 to 3 millimeters in depth, although he didn't mention the thickness of the soft tissue. But the bottom line is, according to research, average thickness of the cortical plate's about close to 1.5 millimeters, and in the mandible, it's just around 1 millimeter. So if you add that to the perforation, then you're thinking that just to get in that cortical plate and to create enough cytokine release, you want to really go around 3 millimeters in depth. And for the mandible, 3 millimeters, except for the posterior. It's usually about 5, especially for brachycephalic patients. That's why I mentioned the phenotype. You have to adjust it based on tissue thickness, any exostoses if you're going to go into the lingual, which I seldom do, and then the phenotype. Okay, so when you think that the tip is 7 millimeters in length, you really are going to go just a little over halfway. And then you should also be concerned and cognizant of anatomical differences. When I was first doing this, I wasn't thinking about that until I went back to the anatomy and realized when you go in, you want the tip to go in perpendicular to the bone. If you go in, you find that it's bouncing out and you don't feel any traction at all, you know that you're not going at the right angle. So all you have to do is simply retract, reorient, and the needle or the stainless steel tip and go in there. And once you find that you get some traction and it starts engaging, then you know your entry point is correct and actually perpendicular. So the real concern that you have to have is in the maxilla. So I find that I'm really getting up there. That's why you really need the accelerator PT, because I have no trouble orienting the screw. I did when I had the RT accelerator, but with this, it's not a problem. I don't get patients complaining about my, extending their cheek retraction to a point where they're uncomfortable with it. And also in the mandible, especially on these brachycephalics, in some situations, I'm going practically vertical into the bone in order to get my traction because you've got this huge ledge on some of these patients. So be cognizant of the fact that you want to focus on going in perpendicular. If you go in and you find that you're bouncing out of it, retract and reorient it until you engage. So let's take a look at some cases. Let's take a look at some adult cases first. And this is the one patient that I constantly go to because she really changed my entire orientation towards MOPs, and it was totally by accident. So I've always been really reactive rather than proactive. And here she came in. She already said to me that you can see I've had fixed braces. I had 4 teeth taken out, and she said, and I still collapsed. And you know, she was concerned about the significant crowding in both arches. She didn't say much, but you know, she said she was just embarrassed by her smile. So I went ahead and she was anxious to get going, so we had and scanned her. And when the trays came back, I just did the math, and those were the days when we were flipping them out every 14 days. So when I did the math, I told her, I think we'll be finished in 18 months. And she proceeded to break down and literally cry in the chair. And I'm thinking, now what did I do? And then she said, no, it's not you, Dr. Brigham. I was hopeful that I could be finished for my daughter's wedding. And I said, well, when's your daughter's wedding? She goes, 8 months. And I'm thinking, wow, why didn't she come in a couple months before the wedding? So I said, all right, you've only got one shot here, and that's with MOPs. And I explained it, and I said, we're going to have to go 6 to 6 upper and lower. And she said, if I do this procedure, do you promise I'll be ready for the wedding? And I said, no, only God makes promises of that nature. I said, but my experience is I think that we've got a reasonable shot, or else I wouldn't bring it up. She said, all right, let's go ahead and do it. So that's what we did. We were shooting for the wedding in 8 months, and she finished in 6. 34 aligners. She flipped them out every 3. I never tell them every 3 days because patients don't always wear the aligners every 20 days. We teach them what good tracking is, and we let them self-monitor. Now that we have dental monitoring, we can keep track of that, which makes this treatment go very fluid. But she was flipping them out every 3, 4, 5, 6, or 7 days, depending on her tracking, and she still finished in 6 months flat. She had time to do a whitening, so we offered her glow whitening in the chair. And so we were able to monetize the patient further and make her a real happy patient. She came back from the wedding and she said everybody thought I had crowns or something because they couldn't believe I straightened my teeth in such a short amount of time. Same thing with this gentleman. You know, the problem with him is he works out of state, so he had significant crowding. And to me, I told him that in order to get a nice, better incisor display and a nice smile arc, we were going to have to do a comprehensive Invisalign with acceleration with MOPs. And he said, Doc, go ahead and do it. And so, and you can see the perforations. We're not doing a lot of perforations here. It's very, and especially on the lower, just 1 perforation per chair, per tooth. So the reason why I'm showing you the ClinCheck is just want to show you how much work it is to actually incorporate a smile arc and give patient greater incisor display. Because for every 0.1 millimeter of extrusion, you have to first conduct an equal amount of protrusion. So that's what we're doing here. We're getting the protrusion and then the systematic and simultaneous retraction and extrusion. So that's a lot of aligners. In the olden days, this would have been a 20 aligner case, but now that I'm trying to incorporate better aesthetics for this type of case, let me get rid of the attachments here and get rid of the grid and give them a nice 12-2 smile arc. It takes more aligners. But for me, it's worth it. And I can tell you the patients are pleased with it. And that's what we present to the patient. I tell them, we want to give you a smile arc. We want to fill the buccal corridors. We want the incisal edges to follow the contour of your lower lip, but I can't do that without MOPs. So when doctors ask me, how do you sell MOPs? I don't. I just say, I show pre and post treatment photographs, show the patient what the possibilities are, and tell them if you'd like to get something that's comparable, we're going to have to do MOPs. And you know what their answer is? Okay. And then we got some patients that are in a bind. And this patient had already had orthodontic treatment, and she'd been going through sleep apnea appliance and therapy for 3 years successfully. But if you're going to be doing that for a long time, what invariably happens is the daytime splint doesn't work anymore to get you a normal occlusion. Now she's muscle splinted forward. It's a good thing because it keeps your airway open, and that's important. and that's why she's going through the sleep apnea therapy. But the problem is now she can't masticate, and she's a little upset. And she said, and I don't want to go through another 2 years of orthodontic treatment just to get my back bite, back to where I can chew again. And I said, well, we have a solution for you, and it's MOPs. And I said, and the good news is you already have the good arch form from your previous orthodontic treatment. All we have to do is limit the MOPs to the upper and lower anteriors. Because what I really have to do is I really have to change her interincisal angle so she can actually go ahead and hinge axis close in that forward position. I don't want to bring her back. I want to keep her forward into her new therapeutic bite. And you can see at this time we were still using the BTT, so you can see the gingival sloughing, but you can see that the perforations were simply limited to the anterior teeth. That's all I wanted. And here she is finished. 40 aligners, 5 months and 3 weeks. She couldn't believe it, in 3 to 5 days. Now, and here she is 3 years later to show you simply, it just holds up. It really holds up. And checking her condyles, she still has some functional remodeling, but I'm not unhappy with her condylar position and the state of her health. I don't see any significant degenerative joint disease, but I see a lot of functional remodeling. And her airway, minimal axial area, is still well within the limits for sleep apnea. Here's another case. Came in, the patient wanted a perfect smile, but she was returning to the Philippines to see her family, who she hadn't seen in years, and she wanted all of this cleaned up. She noticed the asymmetry in her upper arch, and she was disturbed by the significant crowding. And so I said, well, we have a solution for that. It's MOPs. And again, you can see now we're getting a little bit better with these perforations. We're using benzocaine and lidocaine at this point, and the accelerator RT still. We hadn't graduated that, but I'm getting a little bit better with the perforations, so they're not as sloppy. But you can see we were doing 2 perforations, and in the lower perforate 2, only where we were going to get some significant tooth movement or axial inclination change. And again, we're on a time frame here for this patient. She's very anxious about that. Once again, they're all looking for guarantees, and I just say, no, we can't guarantee, but I wouldn't recommend it unless we had a decent shot at it. And so that's what we're looking for. I'll get that out of the way. But we've got to get her out of that deep bite, and we've got to clean this all up. And this is a lot of crowding. And I liked her arch form, so we didn't have to get a lot of arch form, and that's why we didn't go significant with the Propel. We just used it where we needed it. So that's why I was only doing 1 perforation, except on the where I needed to get some significant axial inclination on some of these teeth. And here she is finished. 76 aligners, 14 months and 2 weeks of treatment on a 3 to 7 day aligner exchange. Everything cleaned up, filled the buccal quarters because we changed her arch form, got far better symmetry, arch symmetry and coordination, and we got the smile arc that we're looking for. She was very happy. And this patient, now, she's already had orthodontic treatment, and she said that the orthodontist simply couldn't correct her this open bite type of scenario. And now that she's a dental student, she's very concerned and noticed that on her 2 central incisors, significant fremitus. And if you look at it closely, you can see the upshot of that. It was actually creating some gingival recession, which she noticed because she's a dental student. And she wanted to get a perfect smile in time for graduation in 14 months. So once again, the solution is MOPs. You can see the cephalometric profile. I don't have to worry about, she's already nicely paralleled with that, but she does have some root resorption at the edges of her central incisors, possibly due to the previous orthodontics, but quite possibly also due to the fremitus, because if you're banging on that consistently, something has to happen. Form follows function. If you have abnormal function, you're going to get some type of abnormal form down the line. The cephalometrics, you can see that she's a little high angled and not the best facial axis here. And that's important to me because I've got to make sure that we get a good smile arc out of this and good gingival display. You can see that she's got some significant functional remodeling in both TMJs, and that's probably and that's what I see when you have zero incisal guidance. So it's not good enough just to close the open bites. You have to give them some function too, and that's what MOPs imparts to you. It gives you that chance, and that's what I meant at the beginning of the lecture, saying it gave me an opportunity to really do more for these patients and do it in less time than I did when I was first doing this. So the key was to preserve the incisor display by intrusion of the posterior teeth. It would have been very easy to go ahead and just extrude the maxillary teeth, but it would have increased her gingival display. But more importantly, I think it would have also increased her gingival recession. So it was important to attack the problem where the problem is. And you can see the extent of her open bite here when we put her back into more of a centric relation type of scenario. And at this time, we were using benzocaine and lidocaine anesthesia along with the accelerator PT. Look how clean that is compared to the other procedures when I was using the hand and RT and also the BTT. A lot cleaner, a lot greater patient confidence. They take a look in the mirror and say, that's not bad at all. They don't even give it a second thought. And also, when they come out of those type of situations, they recommend it to other patients and their friends. So this was the key. The key was I'm using all this anchorage here because I've got to lift all these bicuspids and molars so that I can get this hinge axis of closure so we can get the function that we want and still only extrude the incisors to the point of getting a smile arc out of her. And that's what we got. We got the smile arc, filled her buccal corridors, got her the function that we needed, all right, and did it with 76 aligners in 12 months. Think about what this would have taken. And believe me, I had those times when 3 years of aligner therapy, and those days are dead and gone since I've embraced MOPs and incorporated this as a modality in my practice. So here she is pre-treatment. Here she is post-treatment. You can see we did not increase her gingival display. We did not increase her actually, if I use my imagination, this seemed to improve a little bit, but it's probably because she doesn't have any fremitus anymore. And there's a cephalometric profile. You can see that the root resorption, I don't think it increased at all. And she's certainly stable. And the width is good. We got her into a good interincisal angle for her craniofacial architecture. It's within the norm. Let's take a look at some teen cases, all right? This was the first teen case that I did, and the reason why is he was leaving for soccer camp, so he's going to be out of state for quite a long period of time because he's serious about soccer, and he only wanted Invisalign, so I said there's only one way to go, and that's with the acceleration with MOPs, and he jumped on it right away. He said, let's do it if I can get out of treatment faster. So we did it from 6 to 6, upper or lower. So by this time, I'm doing a lot of this. I was still using the RT, so you can see it's not as clean as the PT. That's why I only use the PT. I mean, just showing the clinches to just show you there's a lot of work to be done. There's a lot, it constitutes a lot of aligners, but when you're doing MOPs, I think it really facilitates the tooth movement. I get far better results, and more importantly, I don't get untracking of the anterior teeth the way I normally do without the MOPs procedure. So there's his smile arc. We filled the buccal corridor. He's got excellent coordinated arches and nice rounded arches, and he's happy. You know, and he was happy to get out of there quickly. And that was with 9 months and three weeks of treatment. In the olden days, this was a 18-month procedure. And then we've got this patient came in and he was told by 3 other orthodontists over a period of years that he needed surgically assisted RPE. And you know, something 10 years ago, I would have agreed with that perception. But he said he didn't need the surgery simply because he couldn't afford it, and he was actually apprehensive about going there and do a surgical procedure. And I told him, well, we can do this for you, but it's going to take 2 MOP procedures. Otherwise, you're going to be with me for 2.5 years and you're going to get burned out and you're going to walk away discontented. And he said, Doc, if you can do this, with that procedure, even if it's 2 procedures, I don't care if it's 3, as long as I don't have to spend the money or undergo the surgical procedure. So you can see the MOPs went all the way back. By this time, I'm routinely doing 6 to 6, and I've got my accelerator RT, that was a real handful at that time. And all I'm going to do is just show you, we've got to really change this arch form and get them out of crossbite. I don't think we're overextending ourselves in terms of what's reasonable in terms of arch development, but this is where the area that we need to concentrate on. And with MOPs, that's exactly what happens. So we're only 9 months into treatment, we're completely out of crossbite. And so now we can work on, his gingival display, we can work on the smile arc and try to get a little bit better occlusion. You can see I've got him all dressed up with elastics now, and it's now time for his second MOP procedure at Refinement. And here's his final photos. He's got the smile arc he wanted. He's got the nice broad arch form, full buckled corridors. And he's got a relatively decent occlusal scheme, and he's completely out of crossbite without any surgery. Now, I never thought in my wildest dreams that I'd actually have a patient come in and say, first of all, I don't want to be here. And second of all, I don't want to be in here long. So don't you have this procedure where you go into the bone and you can make it go faster? This kid's 13 years old. And when he actually asked me for Propel, I said, would you mind, I do these in-house courses, would you mind being one of my demos? And he said, sure, go right ahead. Not only did we do one, but he asked for it a second time. So I had him at another in-house seminar, and he was a patient again so that the doctors could see. And they were asking him, isn't this a problem? He said, no, there's no big deal at all. He said, I just want to get out of treatment. Now, he's a severe class 2. He's a width of 6.1. His interincisal angle is way off the charts. He's got almost 6 millimeters of overjet, and he's got an impacted canine. So the reason why I plan 2 MOPs is I plan to expand, make the space, then do a surgical procedure with MOPs to help facilitate getting that in. But to my surprise, after one MOPs procedure and 1 round of 35 aligners, the tooth actually poked its way through. If I would have thought about it more, I would have actually planned for more space, and it probably would have done better. But I actually thought I was going to have to submit him to a surgical procedure. So this kid's rolling. Now, I purposely kept that out in the open because I wanted to get the distal root tip first, and that's what I usually do on high case angle cases. I mean, the high canine cases. I'll get my distal root tip first, and then on the second round, then I'll bring this down. I find I get a lot better results with that. So now we're working on the refinement after the second MOPs. Now we've got a nice buccal corridors. We've got a good smile arc. We've got a good occlusion with coordinated arches. And after 93 aligners, he's finished 15 months with a 3 to 5. And I got to tell you, when he got out of the chair to say goodbye, he actually gave me a hug. It's not going to happen in this COVID environment anymore, so I'm going to miss those hugs. But I walked out smiling. I'm not unhappy with the root parallelization, which is really significantly facilitated with the use of MOPs. And I'm not unhappy with his profile. And then also there were the times when occasionally I'll have these challenging tooth movements. And this patient came in. She was excited about undergoing her Invisalign procedure. And so when she came in, we delivered it. I did some of the IPR. And so I scheduled her for 6 weeks, and she said, oh, no can do. And I said, why is that? And she said, I'm going on sabbatical for a year. And I'm thinking, it would have been nice to know that ahead of time. So I said, get back in the chair. So I told her I finished all the IPR. It wasn't pretty. And I told her, I said, when you're down there, I gave her all the aligners. I said, if you have any problems with tracking, take a selfie and text it to me and let me know. And if you have any significant problems and you can't come back to the States, I'll try to find someone in Mexico for you. I said, are we clear? And she said, absolutely. So let's just take a quick look at what I anticipated. And anticipation is always quite different from what you get, but you can see doing all this IPR in one sitting was not good. All right, let's lock this in first of all. There we go. By the way, those orange things are just simply the power ridges. But you can see this was the key right here. And I told her to focus on that and watch that. And she said, I've got it. So we're looking for good arch form, looking for good occlusion, and we're going to pray a lot. So she comes back 1 year, and we've got this. We've got the good arch form. We're almost there, and this is sticking out like a sore thumb. And so I sat down with her and I said, didn't you notice something odd while you exchanging your aligners about this untracking and getting worse? And she said, yeah, I did. She said, but I didn't want to slow down my Invisalign treatment. I went, okay, perfect. All right. So I gave her 3 choices. I said, number 1, we can crown this, or we can go do fixed appliances to turn this around. She said, no, those aren't good options for me. I want to stay with Invisalign. I said, all right, then we have only one option left, and that's that you're going to have to do Propel. And she said, okay. I said, and you're going to have to wear these things 28 to 22 hours a day, and that will enable us to flip them out every 3 days, but you can't deviate from that. Otherwise, this is going to extend. And she said, okay, let's just do it. So we went ahead, set her up for refinement. When the aligners came in, we did the Propel. Here we go. Now, if you notice, I've got a lot of aligners. I purposely slowed down the velocity of tooth movement because I wasn't quite sure this was going to work. So I threw everything at this patient to ensure that that tooth was going to turn around. And I mean everything. First of all, 52 aligners. She didn't even have close to that number in her first round. 52 aligners. I'm going to blow this up for you. I want to make sure we had good spacing. I added an additional attachment. So I had 2 attachments to help for a while. And you can see all these aligners are just dedicated to one tooth. I mean, there was some movement in the first 5 aligners, the rest of the arch, and that was it. Same thing. Just make the space and turn that around and hope this thing works with MOPs. And there she is finished. And I wasn't unhappy with the result. More importantly, I was happy to get this done under 6 months on a 3-day aligner exchange. She was compliant because she was tired and she wanted to get out of this. And I said, all right, we're out of here. So there are some contraindications to MOPs, and one is ASA 3, systematically compromised patients with severe systemic disease, any patients that are requiring chronic ibuprofen or steroid treatment, and patients treated with bisphosphonates. And also now in this COVID environment, we're not treating any patient with a temperature over 100 degrees Fahrenheit. So that's why it's important to take that temperature. And as far as how do you monetize MOPs, these are procedural fees. There's a range anywhere from $850 to $1,200 for 4 quadrants. And this is really our go-to, because if I'm going to subject anyone to anything, since we're looking for that broadened arch form and to fill those buccal corridors, we're going 6 to 6, upper and lower. If we're trying to intrude maxillary posterior teeth to close an open bite, or a vertical class 2 so we can take advantage of the hinge axis of closure of the mandible, then we're going beyond the 6 and we're actually getting a perforation mesial to the second molar. That's very important in order to get the intrusion that we want so we can get the closure that we want. If we're doing a single arch, the interiors only, it's 600. And if we're doing a single tooth, 300. Now, it's important to follow the dental codes if you want to get paid. And it's important to use these particular codes because insurance we find will cover anywhere from 50 to 90%. If the patient has insurance that's contracted by an office, and we are contracted with Delta Dental, then the fee is determined by the insurance. So this is the Delta Dental fee. So now it's limited to $213 per quadrant, but once again, if we're doing 4 quads, I'm more than happy to do it at those fees. Now, if the patient has no insurance, then the fees determined by the office. And then we do our usual and customary fees. What I want to, it's a unique experience dealing with insurance companies, as I already know. So when billing an insurance company, be certain to bill for each individual quadrant that's completed, and you have to actually stipulate the exact tooth number. This is critical. If you make one error by omission, they will deny it. And then you'll think they're denying MOPs. No, they're denying your procedural modifications and also the way you've documentation. So don't get denied because the way you've documented your procedure, okay? So in summary, invasive corticotomies affect significantly accelerated orthodontic tooth movement, but they're simply not conducive, from a patient and doctor standpoint. Acceleration of orthodontic tooth movement with MOPs is easy to conduct. It's minimally invasive. It's financially productive, and the procedure is based very well into science. And both conventional updated MOP protocols can still be elected based upon individual doctor preferences and whether they want to go to the next level, which I highly recommend, and just go out and get the PT accelerator. You won't regret it. And MOPs can be applied to accelerate clear aligner cases comprehensively, or you can eliminate to specific challenging tooth movements. When I first started, I was eliminating it to individual tooth movements, but I quickly cast that aside and just went 6 to 6 upper and lower, and I'm happy that I did. And with the accelerator PT, does not disrupt practice flow. So our experience with MOPs, I really felt that when we came back into the office, there would be some hesitation. And I have to tell you, the first week back, we did 4 MOPs procedures, 6 to 6 upper and lower. The second week back, we did 3. And as of this week, we've done an additional 2. So that's unbelievable to me. It's almost 10 procedures within, and we haven't even finished the 3rd week yet. So I'm surprised, but on the other hand, I'm not surprised. Patients are focused on acceleration and staying out of the office. And if there's anything that can do that, and when they saw our additional procedures, and some of them have actually expressed appreciation for what we've done to our office to prepare them for this, they feel safe, they feel comfortable, and they feel confident with the MOPs procedure. So there's a tendency, and this is for all of us, especially me, that when we're working toward a solution, there's a tendency for the brain to stick with familiar ideas. And if you're sticking to these ideas, it can literally blind us to superior solutions. And I found that once I got over the hump and embraced MOPs and incorporated into practice, I found a better solution for orthodontic tooth movement. So might as well plug ourselves with my colleague, Dr. Glazer. We've turned our in-house courses into mini residency. It's a 12-week mini residency. It's about to be launched next month. And if you're interested, the inquiries go to glazerorthodontics@gmail.com. We're going to have 24 separate webinars, averaging about 2 a week. And the best part is you can view them at your convenience. So I don't never take for granted you're sitting there for a webinar, so I want to thank you, and I'm more than happy to field any questions. All right, the first question, John, welcome, it's great to have you. What's your protocol for dental telemarketing? Thanks again. Well, the bottom line is that, let's see, I'm sorry, we jumped a few. All right, just curious, on patients with thin gingival biotypes who are prone to gingival recession, have you observed any difference in post-ortho recession with patients that you do? I'm glad you asked that question, Doctor, because the bottom line is that I have. In fact, I even show those cases in my comprehensive complex course. So yes, I have done that, and there has been no sequela for it. And but I do have to tell you, on all these cases, when I do MOPs on these compromised cases, I also include a high-frequency vibration device because it ensures that we don't lose any bone. So very happy with that. Doctor, is an assistant helping you when you use the handpiece? As I recall, it is tricky to go forward and then reverse back and forth. Let me tell you this. I started at the beginning because I saw other doctors were doing it, and to me it was clumsy. And actually, the more you do, the better you get on this. So no, I don't have I don't want the auxiliaries hands on the device. So I'm just going back and forth myself. And it was clumsy at the beginning, but with practice and with doing more, you'll find you start to get more fluid with it. And then you find that's not a problem at all. And to use sterile saline to irrigate areas when you do the actual Propel procedure, and are using surgical gloves. We're using the gloves that we now use for COVID, and you know, they're not surgical gloves per se, all right? And now with the COVID-19, are you using relief or isolate to help address aerosol concerns? And the answer is no, but we have, that's what the auxiliaries there, and we're doing, we have this high vacuum situation that we've got going, and it really helps significantly. And do you ever use a monojet for the anesthetic instead of a syringe? And the answer is no. I know some people do, but I'm real comfortable with the syringe. And the bottom line is I'm not doing any long buckles or anything like that, or you know, the intraalveolar nerve. I'm just doing this infiltration, and it works very well. It goes very quickly, and I've learned to target certain areas like buccal frenum or anterior frontal attachment because it's very rich in those nerve endings, and that's where you get the greatest sensitivity. So I'm knocking that out with benzocaine and then hitting it with the lidocaine, and then I don't get that, I feel that in the middle of the procedure anymore. So just curious on patients with thin gingival, oh, we've already answered that. And then what's your protocol for dental telemonitoring? And thanks again. Let me tell you this, I've embraced dental monitoring. And I think we've got about 120 patients now in dental monitoring. And so yeah, I got to tell you, there's no recourse with this. The patients don't even bother with it. They go through this so easily, and they love it. They love the results. And as of last year, for the first time, you know, I was used to patients coming and saying, how can we help you? And they were here for Invisalign, obviously. But for the first time, we're here for Invisalign and Propel. I never thought I'd ever see that. But what happens is Propel patients tell other Propel patients. And when they see the results, it brings in other patients. So I'd highly encourage you to embrace this. Let's see, it's where do you suggest one starts to learn to get further training on looking at condyles and reading CBCT or tomograms to probably diagnose the case? All right, I'm going to tell you, first of all, Dr. Mao, he's the clinical director at UCLA, and he's one of the most brilliant people that doctors that I've met. He has a CBCT course. At least I hope he still does. Like myself, he may be turning it into webinars. He also does the soft tissue course that I took to learn how to do Botox in the masseter muscles for these brachycephalic cases, as well as doing some lip enhancement. So I would highly recommend. He teaches an excellent course, and he's very patient, he's very compassionate, and he's one of the best practitioners and teachers that I've ever run into. And where can one look to study smile arc and smile design? I've learned, I have to give credit, first of all, to not only to David Sarver, because he started all this. And he actually even said, I didn't even mean to start this. I was just trying to get a little bit better result. But where I've really gotten the basis for this is Tom Pitts and Duncan Brown. I think they're the masters of it. And also they're the team of all the patients or the doctors that have gone through the Pitts Masters course. And we continue to struggle with our smile arcs. But even when I only get part of the way, patients really know the difference. And I can tell you right now, do you know what's bringing in patients now? Propel, Invisalign, and smile arcs. Patients are coming and saying, we'd like you to do that thing you do. I tell them, well, that's, first of all, that's a Tom Hanks movie. But if you're talking about smile arcs, we'd be more than happy to accommodate you. And thanks again for reminding me how incredibly much I do not know in every one of you. John, I love you, seriously. And that's not true at all. And I really appreciate you joining it. And it's always a pleasure to see you on these webinars. I really am deeply humbled by that. And great overview on MOP and iCat. And is a vibration device from Propel? Yes, it is. And I'll be giving that webinar at the end of this month. And I hope if you have an opportunity to join us, because there's a lot of controversy on pulse vibration, and I hope to clear that up for you too. And then you also said, how do you set up the occlusion with your ClinCheck? Well, that's a whole different webinar, and I hope that because I do have a stepwise approach to that, and that's in our webinar series with Glazer. And but Dr. Chan, I've known you for a long time, so just give me a call and I can help you with that, especially with the heavy posterior occlusal contacts with the interior teeth, because posterior open bites due to heavy occlusal contacts are the #1 problem with Invisalign, and I try to address that in every single Align webinar that I do. And then how do you manage payments with treatment time and so much more shorter treatment time? I assume you're talking about MOPs, Dr. Yee, and if you are, I can tell you this. Once you get that insurance, and we submit it immediately on the same day, it comes back very quickly. So, and they pay right up front. So you're going to find that you're going to get those payments very quickly. Why? Because you've done the procedure already, as opposed to Align. When I submit for Invisalign for insurance payments, they're going to spread it out over the duration of the treatment. They're not foolish, they know. But with MOPs, it's automatic and you get it immediately. And I got to tell you, in this COVID environment where the practice is really slow, it's MOPs that's been really helpful in terms of compensation and bringing and helping monetize the practice. So again, I see so many familiar faces, and I'm very gratified and humbled that you came to join me. And so thank you, and I look forward, and hopefully you can join me for the high frequency vibration pulse webinar that I'm going to be presenting at the end of the month. So thank you again, and take care.